Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. All right, I came across this article about GLP-1 agonists and how to mitigate some of the lean tissue or muscle loss that sometimes happens with these drugs. It came into my inbox from Medscape Medical News, which is a pretty good site, actually. They have a lot of useful information in there. But the title caught my eye. It said, "Losing Muscle with GLP-1 RAs, Receptor Agonists. There may be a drug for that." Of course, there's always a drug, right? If you have a side effect with one drug, don't worry, we got another drug. It's going to help you with that side effect. If you have side effects with that drug, maybe we got another drug that can help you with that too. So that seems to be the way it goes in the pharmaceutical and medical world these days. So anyway, I want to talk a little bit about these drugs because it is true. People that use these drugs, and I'm going to caveat this by saying people that are prescribed these drugs inappropriately and without the proper framework in which to fully utilize these drugs in a proper manner, yeah, they do lose a lot of lean muscle tissue. Anybody that has drastic weight loss, especially drastic rapid weight loss due to a calorie deficit, whether it's from GLP-1 drugs, gastric bypass, or just regular old school dieting, yeah, you're gonna lose muscle tissue. Now, we'll talk about at the end. I have some strategies that I think can really help with this that don't necessarily involve the addition of a pharmaceutical agent, but we'll get into that. We'll get into that here at the end. So this article starts off, it says, as drugs such as semaglutide, which is Wegovy, and the dual agonist glucose-dependent insulinotropic polypeptide, GIP/GLP-1, tirzepatide, otherwise known as Zepbound, are producing unprecedented degrees of weight loss in increasing numbers of people, concern has arisen about the proportion of the lost weight, approximately 30 to 50%, that is beneficial lean body mass versus fat mass. Yeah, and that's true, actually. If you look at the data, that's about accurate. People that were in these clinical trials with these drugs, they obviously lost a ton of body weight, but a lot of that was muscle tissue. A significant proportion, up to 30 to 50%, was actually muscle tissue, and that can have some serious long-term ramifications. Muscle tissue. Any of you guys that follow my content, and there's actually a number of other physicians out there that have been saying this even longer than I have. Muscle tissue it's very precious. It's extraordinarily important for your overall health, not just your metabolic health, but your day-to-day function, your quality of life. Muscle tissue is something that, in my opinion, you need to put extra effort into not only building, but then also preserving as you get older. So if you found yourself in a position where you have excess body fat to lose, you obviously want to get that body fat off, but you need to do it in such a manner that you minimize the sacrifice of lean muscle tissue. And there will always be some lean muscle tissue loss. I mean, even professional bodybuilders that go to extraordinary lengths in contest preparation with, mega doses of androgens to preserve muscle tissue, even they lose. If you put those guys into a DEXA machine as they prep for a contest, there's even those guys lose muscle tissue. So this is just something that happens. But there's going to be some strategies that you can use to mitigate that. But Big Pharma has an idea for you here, and that's what this article was about. This article actually, it talked about some data that was presented here at the American Association of Clinical Endocrinology, their annual meeting here in 2004 that actually just happened in New Orleans, and there was a number of presentations and papers that were presented here that I might talk with you guys about in the future, but this is the first one that I wanted to touch on. And so they talked about a clinical trial with a drug called enobosarm, which many of you may recognize as ostarine. Okay, ostarine is a SARM, a selective androgen receptor modulator. It's probably the most studied one out there. So Big Pharma has come to the rescue here, and what they're doing is they're trying to combine ostarine with a GLP-1 agonist in the hope that adding ostarine will mitigate some of the lean tissue loss that people are experiencing on these drugs. So they're not focusing on some of the lifestyle things that you can do. They're not focusing so much on nutritional and exercise strategies to mitigate the lean muscle tissue loss. They're just going to add in a SARM to see if they can mitigate the muscle loss. They said data presented in 2 late-breaking posters at the annual meeting of the American Association of Clinical Endocrinology laid the groundwork for subsequent phase 2 trials of enobosarm, or ostarine, in combination with a GLP-1 receptor agonist. One showed increased total lean mass and decreases in total fat mass with 3 milligrams of enobosarm for 14 days. So short trial, right? In both healthy young men and older men, which they defined as greater than 60 years old, with the greatest benefit seen in older men who had lower lean mass and higher fat mass at baseline. And one of the scientists in the trial was quoted as saying, "Wouldn't it be nice if there was a drug that built up muscle mass?" Yeah, wouldn't that be nice? Gosh, I wish I could think of a drug that would build up muscle mass. I think what he actually meant was, wouldn't it be nice if there was a drug we could patent and make millions of dollars from that built up muscle mass? Because I know, because if I know this, I know that he knows this. There are plenty of strategies, plenty of drugs out there. We're going to call them drugs. They're actually naturally occurring hormones that are in your body right now, one of which is testosterone, that is more than adequate, and I'm going to show you some data, is vastly superior and vastly safer to the addition of a SARM, let alone ostarine, as part of a regimen using GLP-1 receptor agonists. So the problem for Big Pharma, with testosterone is that it can't be patented. You can't patent a natural hormone. There's no money in testosterone, but there could be a lot of money in ostarine. If they can get this approved, which I guess we'll talk about that. I have my doubts whether this will ultimately get approved, but if they do, just wait. Just wait. It's they're going to make a lot of money off this combination. So, but anyway, this quote just jumped right out at me. Wouldn't it be nice if there was a drug that built up muscle mass? Oh, if only there was a way. You guys are hilarious. Okay, so I'm not going to get too much into ostarine. This is the chemical structure of it here. As I mentioned, it is one of the most studied SARMs that are out there. There are obviously many more SARMs out there. I am not a huge fan of any of them. I don't think they should be used really for anything, in my opinion, but that's just my opinion. So right now, in addition to this GLP-1 agonist combination therapy, they're also looking at it as a potential breast cancer drug. So apparently it's in phase 3 clinical trials for breast cancer. So we'll see, there may be some utility there. But these SARMs, the idea behind them, they were designed decades ago to interact with the androgen receptor. And they were, ideally they act as an agonist in muscle and bone tissue. So they help you build muscle just like a anabolic steroid would. But they are either like a partial agonist or an antagonist in other tissues where you don't want to have androgen action, for example, like the prostate. So that's kind of the clinical rationale for the existence of these drugs. None of these have made it into prime time yet. They all have serious problems, and that's why I kind of doubt that ostarine will ever see the light of day and make it through the FDA approval process. But who knows? I could be wrong. When these studies started showing people losing tons of muscle tissue on these GLP-1 drugs, I think the knee-jerk reaction among a lot of physicians was that there was something inherent with the drugs themselves that was essentially catabolic, that was actually promoting this muscle tissue loss. And that's really not the case. These are fascinating drugs. This is a really interesting diagram of how these GLP-1 agonists work in various tissues. And it comes from this paper here. It comes from the journal Cells, which is this is a fresh 2004 article, GLP-1 receptor agonists effects beyond obesity and diabetes. Pretty good, like up-to-date summary of how, just mechanistically, how these drugs work. Just briefly, So they work at the pancreas, so they promote insulin secretion. But the really amazing thing about these drugs is that they are somewhat protective of the beta cell. So one of the things that happens as you get older is you lose beta cells, and certainly if you're a type 2 diabetic, you kind of you can essentially burn out your beta cells, and so you end up losing beta cell activity at an accelerated rate as you get older, and the worse your insulin resistance is. So that's why a lot of type 2 diabetics ultimately end up on requiring insulin injections. So they can be protective in that regard. We now know that these drugs are really helpful for people with heart failure. They're helpful for people with cardiovascular disease. They have now been shown to help with slow the progression of like chronic kidney disease. They can help with fatty liver disease. They actually might have an anti-cancer property as well. That probably needs to be explored a little bit more. So amazing drug, like works in so many different ways. What patients say, and those of you guys that are out there that have used these drugs, you can vouch for this in the comments, but they suppress appetite really, really well, and they lead to early satiety. So you might eat like 2 bites of your hamburger and all of a sudden feel like I'm done. Like I'm full. I don't really want to eat anymore. So the net effect of all this is obviously you just consume less calories. And so you consume less calories, and of course, you're going to lose weight if you do this for a prolonged period of time. And again, that weight loss can sometimes be really dramatic. With some of these drugs, it rivals bariatric surgery. And again, as I stated earlier, when you have rapid weight loss, and especially from a steep caloric deficit, yeah, you're going to lose muscle tissue with that, especially in the beginning, like the first 10 to 12 weeks of a hypocaloric diet like that. You will lose a significant amount of muscle tissue. And then, as time goes on, the proportion, you start losing more fat than muscle tissue, but you can lose a lot of muscle tissue right up front, like in the first, say 3 to 4 months. So it's not anything inherent with these drugs. I know there was a couple, popular YouTube physicians that had kind of sounded the alarm bell about these drugs, and I guess we're insinuating that it's something inherent with the drug itself, but it really doesn't look like that's the case. It's really just the steep caloric deficit, and in my opinion, the lack of guidance actually that patients get from their physicians when they are prescribed these drugs. Anyway, so Big Pharma's answer to this is to add in some ostarine into their GLP-1 mix, and there are many reasons, in my opinion, why this is a terrible idea, but this is just a few of them. So this is a paper here from Xenobiotics. 2023 systemic review of safety of selective androgen receptor modulators in healthy adults, implications for recreational users. So they talk about ostarine in this article, but also a whole bunch of other SARMs that are on the market. And then there's this article here, which is actually quite good. 2022 Journal of Medical Cases, drug-induced liver injury secondary to enobosarm, a selective androgen receptor modulator, where they talk about a couple cases of really severe liver injury in recreational users of ostarine. So I can't say enobosarm. I'm just going to call it ostarine from now on. So anyway, the safety profile of this particular drug, in my opinion, is not good. There actually are a lot of case reports of drug-induced liver injury. So sky-high liver function tests, jaundice, hyperbilirubinemia, etc. Most of the time, that's reversible when the drug is stopped, but there are some cases of like fulminant hepatic failure, from this drug. We know it is not favorable from a cardiovascular standpoint, so it will really skew your lipids, in particular your HDL levels. It's likely pro-inflammatory. So there's a lot of properties to ostarine that, in many ways, like they actually counteract some of the benefits of the GLP-1 drug. So in an attempt to preserve muscle tissue, they're going to add in this potentially toxic substance that, like I said, it counters many of the positive effects of GLP-1s. GLP-1s are very useful drugs in the right clinical setting. They have to be used correctly, but in the right person and the right patient who's suffering from the right issues, I should say, yeah, they're super useful. So why would I want to combine this with something that counteracts many of its benefits? So if only there was something I could combine this GLP-1 drug with that would enhance its benefits. I'm just at a loss. I wish I could think of one. Oh, it turns out actually there is. So there is one. Here's a paper in Androgens, Clinical Research and Therapeutics. It's fairly new from 2020. Testosterone therapy for prevention and treatment of obesity in men. Well, what do you know? Great article. I've had this for a while. I think I've talked about this article in the past. So what they did in this study is they took men with obesity, both class 1, class 2, and class 3, which is based off of BMI. It's not that important to know, but class 1 is BMI 30 to 34.9, class 2 is 35 to 39.9, and then if you're 40 and above, you're pretty obese. That's class 3 obesity. And then they had these men on testosterone undecanoate, which is okay. It's not the best way to treat hypogonadism, in my opinion, but it is what it is. But the cool thing about this is they followed these guys out for as long as 11 years. 11 years. And this is the graph here that I think is very telling. They looked at change in percent body weight and change in waist circumference in men with documented, by the way, they all had documented testosterone deficiency. So they actually had another group in here that was people with normal body weight or normal BMIs. And they compared those with people who were overweight and also obese. I mean, look at these charts. So change in body weight, it doesn't matter whether you're normal, overweight, or obese, there was benefit here in terms of all of these men lost weight. And the thing that's interesting about all of these graphs, they go out for 11 years. The benefits just keep happening. So it's not like a lot of drugs that, maybe there's benefit for 6 months or a year, and then after that you've maxed out your benefits. No, not in this case. So in this study, these men continued to lose body weight, and they continued to lose, they continued to have a decrease in their waist circumference going out 9, 10, 11 years on testosterone. So this is a drug, and I don't even like to call it a drug. We'll call it a drug because it's an ester, but this is a hormone that can be extremely beneficial, and its benefits don't stop after a limited amount of time. They continue on, and presumably if we followed this curve out, maybe another 20 years, obviously you would expect some flatlining to occur, but at least out to 11 years, there's still significant benefit for these guys in terms of their body composition. So what happens if you have low testosterone, you're overweight, which that's a super common combination, obviously, and you put these guys on a low-calorie diet, but then you also correct their low testosterone. So you're sort of simulating a situation here, like with a GLP-1, where you're going to be in a calorie deficit over a long period of time. So this particular study here from BMC Medicine, this was effects of testosterone treatment on body fat and lean mass in obese men on a hypocaloric diet, a randomized controlled trial. And this is good because they followed these guys out for over a year. And again, this is a randomized controlled trial, so these are the kind of studies we actually want to see. So they took men who were obese, so BMI greater than 30. They all had documented low T levels, which they defined as total T less than 346 nanograms per deciliter. They didn't look at free T. That would have been interesting to do. I would have loved, all these studies are done with BMI, and I've talked about this before, but BMI, if you just use BMI, it just grossly underestimates the number of people out there that are actually obese or over fat. So we should be using body fat percentage, and I wish that researchers would start doing that. But just logistically, that can be difficult, and it adds to the expense of the studies. But in an ideal world, we would use body fat percentage, but Anyway, so they took this group of men, and then they were randomized. Some of them received testosterone undecanoate every 10 weeks, and the others got placebo. And all of them were put on a very low-calorie diet, and they were instructed to follow a moderately intense exercise program. They had to do at least 30 minutes of exercise every day, and then they would check in with the researchers. They would log their exercise to, make sure they're being compliant with it. And so this is really interesting. So they had two phases of this. There was a 10-week phase where they were on this ultra low-calorie diet, and then they transitioned basically into a kind of a more of a maintenance phase. So this is what they found. Super interesting. So at the end of phase 1, the fraction of weight loss comprising fat-free mass, okay, is pretty much the same actually between the two groups. So if you're on testosterone, 32.5% of the weight you lost was fat-free mass. And remember, fat-free mass, it's not just muscle tissue, right? It's water weight. It's muscle tissue, obviously. It's glycogen, and it can involve including your organs and bone and all that sort of stuff. So it's not just muscle, but we use it as a proxy for muscle mass. But just keep in mind, it does involve other things, including just water. So 32.5% if you were treated with testosterone, and 35.5% in the men that got placebo. So not a huge difference in the 10 weeks. But here's what's interesting, though. At the end of the study, so they took it out all the way to week 56, the fraction of weight loss comprising fat-free mass was only 5.3% in the men with that were on testosterone therapy, and it stayed fairly steady. It was 36.7% in men on placebo. So the men on testosterone replacement recovered a lot of their lean muscle tissue, but they continued to lose fat. So this is pretty impressive. This is, as far as I know, this is the smallest reduction in fat-free mass that's ever been documented in a study, at least up until this point. There might be others since 2020, but as far as I know, this is the best one. So it turns out there actually is a drug that we can do, that we can combine potentially with a low-calorie diet, potentially with induced by a GLP-1 agonist, that could be very, very beneficial for helping us hold on to fat-free mass, especially maybe not in the short run, like maybe not in this first, the 10 to 12 week period, but over the course of, say, a year. And many people on GLP-1 drugs, especially, diabetics, they are on these drugs, especially if they can get their insurance to cover them. You're going to be on these drugs for a long period of time, right? Being on them for a year is not uncommon at all. So it would stand to reason that this is something that your doctor should consider doing. If you're an obese male, first of all, you absolutely need to be screened for hypogonadism / low testosterone. And if you're going to be put on a GLP-1 drug to help you lose weight, it stands to reason that you would want to treat your hypogonadism, right, with testosterone, whether it's undecanoate, cypionate, whatever, topical cream, whatever you and your doctor think is best. That should, according to this study, if you want to maximize the amount of fat loss and you want to minimize the amount of muscle tissue loss, you need to treat yourself. You need to treat your hypogonadism with testosterone, assuming you don't have some other contraindication. Assuming it's not against your personal values, or there's some other reason why you wouldn't want to be treated. If there's no contraindication to it, I think this is something that should be highly considered. So, I mentioned a lot of overweight men have low testosterone. It's exceedingly common, especially once you cross into that BMI over 30, clinically obese category, which, by the way, for men with body fat percentage is 25% and above. If you're above 25% body fat, congratulations, you're considered obese. So this applies to you as well. When you cross the threshold into a BMI over 40, which is becoming increasingly common, I see men with BMIs over 40 all the time, multiple times a day, certainly in the emergency room. 75% of those men statistically qualify for a diagnosis of hypogonadism, and that's even using the new standards, which are much lower than they were in the past. What's scary to me, though, is if you look at teenage men or teenage boys and young adult men, so like in their early 20s, that are obese with BMIs over 30, the hypogonadism rate is like 30 to 60%, depending on the study that you look at. So again, if you're an overweight man and you're entertaining getting on one of these GLP-1 drugs and you've never had your testosterone levels checked, I would strongly recommend it. I think you should strongly consider that, in addition to all of the other things that you should be keeping tabs on: lipids, inflammatory markers, blood pressure, etc. So it's just so common that this is not this is something that I think warrants screening if you're overweight. I mean, obviously there are clinics. I know you guys have seen the advertisements either online or out in the real world. There are telehealth clinics popping up everywhere that are they're providing these GLP-1 drugs, usually from a compounding pharmacy, or with basically just minimal interaction with any kind of provider. So you pay the money, the drugs arrive at your house, and that's it. There's very little in the way of education. There's very little in the way of a comprehensive strategy to help you preserve lean muscle tissue. And honestly, there's almost no conversation at all about like the importance of muscle tissue, or even like the possibility that you could lose muscle tissue and potentially, seriously impact your metabolic rate, which will set you up to regain the weight, because maybe they don't want to have that conversation, because what a great way to get repeat customers, right? Yeah, you'll lose a ton of weight, but now your resting metabolic rate is significantly compromised because you've lost a ton of muscle tissue. And so now the calories that you needed before for maintenance, just to maintain your weight, eating those same amount of calories is now going to start putting fat back on. And guess what? 6 months later, you put the weight back on, and now you're going to come back and you're going to buy some more semaglutide, liraglutide, whatever, tirzepatide, whatever the case may be. So I think it's really unethical to sell these drugs in that manner, to just sort of provide them with a very minimal amount of screening, with a very minimal amount of education, and just say good luck, and off you go. Because I think in the long run they theoretically could do more harm than good. So the strategy that I like to use is I like to sit down with the guys, and we plan this out, and we talk about a goal weight. We talk about getting you there in a nice, slow, and steady fashion. I don't like guys losing weight more quickly, certainly not more than 2 pounds a week, even though in the beginning sometimes it goes faster than that, especially if guys are really, really overweight. But I really emphasize, we identify guys with low testosterone. If they're a candidate for testosterone replacement, we certainly talk about that, and we initiate that. It's extremely, extremely important, though, that they understand that you have got to do resistance training. I basically tell these guys that you should be, when you're on this drug, you should be treating yourself like a bodybuilder, meaning that like a bodybuilder getting ready for a show. And I'm not talking about using all of the extra drugs and fat burners and stuff that they use, but bodybuilders really, they spend a lot of time in the gym. They do a lot of resistance training, because we know that if you resistance train, even in a calorie deficit, it can go a long way to helping you hold on to muscle tissue. If you just sit like a bump on a log on the couch, your muscle tissue is going to melt away along with your fat. So you need to give your body a reason to hold on to your muscle tissue, and that involves spending some good quality time in the gym, working hard, pushing the weights. The other thing is, yeah, granted, you are going to be eating less food, less overall calories, less energy total, but you need to make sure that the amount of protein that you eat is substantial. And in some cases, it's a lot more than guys are used to eating. So I shoot for a bare minimum, usually of 2 grams per kilo, which is, roughly a gram per pound of body weight. But I'll tell you, in older people, like older than 65, sometimes that number needs to be a little bit higher. And I have another video on that, on protein requirements for people based on their age. But keep in mind that that amount of protein is often what's required to also minimize the amount of muscle tissue loss. So you have to have a plan. You can't just take these drugs and then only eat when you're hungry, because you're never going to be hungry, or you're rarely going to be hungry. And when you do, you're not going to eat very much, and you might end up finding yourself eating 1,000 calories a day, which, yeah, you will lose a ton of weight, but you're going to lose a ton of muscle tissue, especially if most of that is just carbs and fat and is not from high quality protein sources. So don't do that. Don't do that. Think about the long term. Work with your doctor, have a plan for the time that you're on these drugs. Have a plan to hold on to your muscle tissue. And the bare minimum of that part of that plan has got to be resistance training, and it's got to be an increased protein intake. And, there may be some supplements that can help you along the way. Something like HMB, beta-hydroxymethylbutyrate's been around forever. It's a metabolite of the amino acid leucine. It comes in a powder. It's absolutely disgusting tasting, but you know what? If you mix it into a shake, you're not going to taste it. It has some anti-catabolic properties, so it has potential to help you hold on to a little bit more muscle tissue. But certainly just making sure you're getting plenty of branched-chain amino acids, especially leucine, in your daily intake is going to be really important. But adding HMB, there is some data to support that. As in older people, supplementing with fish oil might have some additional anti-catabolic benefits. And then, I'm a big fan of creatine, whether you're dieting or not dieting. I think that can be particularly useful when you're dieting, but I use it and I recommend it year round. So you can continue adding that. All these like over-the-counter fat burners and all this other stuff that you see marketed, it's largely garbage. I tend to try to steer people away from that sort of stuff. But the basics are increased protein intake, good resistance exercise, and you could consider adding those supplements I just mentioned as kind of an extra layer of protection. But the core, the thing you're going to get the most bang for your buck, is the resistance exercise and the protein. And just make sure that you're not dropping your calories. You're not going down to 800 calories a day. That's absurd. It's a recipe for disaster, and it's going to result in inevitable rebound of your body weight. So again, I just want to emphasize muscle tissue is precious, okay? You work really hard to build it, but you also have to have a good strategy and a plan to hold on to it when you get to the point, if you get to the point where you want to cut some body fat. So it's have a plan. If you don't know what to do, it's okay. Find somebody to help you. Find a coach, find a nutritionist. You can talk to me if you want to. You can talk to your TRT physician if you have one. There's a chance that they might be able to help you in this department. And if they can't, that's okay. Ask them to refer you to somebody. So there's a lot of good information out there. There's a lot of people that know what they're doing. They'd be more than happy to help you with that. So that's all I have for you guys today. If you have experience with these drugs, either positive or negative experiences, and I realize, we're hearing more and more negative experiences with these drugs, and I would certainly like to hear about those if you've had any yourself. But again, these drugs are here to stay, and Big Pharma they've seen the amount of money that's to be made, and they want to address this muscle loss concern by selling you yet another potentially dangerous drug like Ostarine. Anyway, let me know what you guys think in the comments, and I will catch you next time. Bye.
All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, Practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.